My mission today is to provide you with a perspective from the VC, from a venture capitalist. This is a business perspective on the aortic valve space. Again, my name is Marwane Berrada, and I'm a senior director at the Cleveland Clinic. To provide you that perspective, I think I want to take you a little bit down the memory lane and talk about the history around TAVR. So Dr. Alain Crevier did, obviously with his passion around valves, brought up a field to us, which is the percutaneous valve. Also, we need to give credit to Edwards and Medtronic. They acquired companies, early stage companies that are able to nurture both on the clinical side and the financial side to provide us with devices that we use in today. And this is all about the investment that we want to talk about in the VC perspective. With that, people have seen the opportunities and many different valves have been created. And the question from an investor is, well, out of all of these valves, how many will see the day of light? Light of the day, sorry, and then how many of those will actually be investable or not, and that's the discussion that we're going to have today. So from the aortic valve space characteristics, it's definitely a disruptive technology. It has a very similar outcome than the surgical, so this procedure here to stay, and we know that, and we heard it multiple times. It is a very significant large market. The indications have been expanding from high-risk patients towards low-risk patients with very good data. There's a significant technical improvement from all of these devices from generation to generations, and every speaker here has been talking about that evolution and how that actually impacted. And every strategic today has a TAVR program. So it's not a surprise to us that this is a very large market. In 2020, it's actually projected to be over $2 billion in revenues, just only the TAVR. We have not talked about mitral valve or other type of valves. So this is a very significant market. This is the data that we collected internal to the Cleveland Clinic Business Intelligence. We actually counted about 27 aortic valve companies. Out of those, about 8 have been acquired, 3 have been defunct, and 14 are still active. The St. Jude/Abbott portico valve is an internal development. We total about over $720 million in investment and over $2 billion of return, which is an ROI, return on investment, of about 6 times. This is a very significant and very healthy. So what's left for us to improve? We talked about stroke rate. It needs to be reduced. We talked about paravalvular leakage, coronary obstructions, heart block, reduction in heart block and conduction disturbance, and we talked about leaflet durability for low-risk patients. But I would like to argue that these are all marginal improvements and they're not disruptive enough to actually warrant investment. So we talk about all of these, but if from an investor perspective, this is very difficult for somebody new to build a company around solving these problems alone, because they have to borrow technologies, they have to borrow current devices, and at best what they will get is license to a strategic rather than actually an acquisition. So what is left for us to see here from an investment perspective, and what are the new roads that we can actually take? From an investment, we first ask the question, if I build it, will they come? So it's very important for us to have an understanding who would be the potential acquirer. If we build today an aortic valve business or company, will Edwards come? Will Medtronic, Boston Scientific, or somebody else? So we need to have that ability to answer that question. It has to obviously resolve a large unmet need, and it has to have a large market as well. So also the characteristics of the competitions and the landscape of the technical landscapes are very important. As we talked about, there are 14 active TAVR companies today. So am I going to be the 15th, the 16th? Am I going to make actually an impact into this field if I'm that late as an entry? So the barrier of entry is also very important to us, and also switching costs. So today we talk about self-expanding versus balloon expandable. So if somebody is trained toward balloon expandable, how am I going to drive a training program so I can actually switch that user operator from balloon expandable to self-expanding? And lastly, if I'm a late entrant, how am I going to compete? If I'm early, how much money do I need to actually educate the space? So here's where we stand today. Most of the strategics have a valve, whether self-expandable or balloon expandable. So the first question that we ask ourselves, or at least from a VC perspective, is there any more product differentiation, or are we moving towards a cost advantage strategy in which now to actually gain market share among these companies, you have to actually reduce the cost? We don't have an answer, but it's definitely a question on the table. And how about the rest? Are other companies will come in? And if they come in, how will they disturb the market? So my interest here in the aortic space are actually fourfold. Aortic repair for aortic stenosis. I want to address a little bit of aortic regurgitation. We haven't heard a lot of people talk about it. Some leaflet engineering, and then TAVR outcome prediction and patient stratification we've talked about earlier. In aortic repair, very out-of-the-box thinking. Cardiovascular is doing a pretty good job at pushing this invention. It's still an evaluation, and the approach is very intriguing. Can we do one-day aortic repair to help our patient? Aortic regurgitation. We started dabbling into this. We started using our current devices, actually, in aortic regurgitation patient. However, they have a different etiology. If you look at the valve itself, there's no calcium. There's no way for us to be able to line up our devices. There's no way for us to have those devices grab onto something. There's no calcium. So is this a good opportunity for the field to go design new devices? The NF valve, as an example, has a foray into this. I'm very interested to hear what they're going to be coming up as far as clinical results. Aortic regurgitation prevalence is very similar to aortic stenosis. So why don't we go into it as perhaps a field? And obviously you can see here patients don't do well when they have a high classification. This is, it was a surprise to me. Dr. Mack and I, we did not communicate before this. And then we had the same idea. So Excerpt, absolutely. You explained, it was explained to us how it worked. For us, this is very, very exciting. This company has raised 45 million euros. They're actually in Netherlands. They're thinking about coming to the US, and this is going to be very interesting to see how this will pan out. In the same vein, so this is another tissue, polymeric tissue. This is actually a polymer that is coated with HA. As you can see from those images, it has very good properties for actually reducing the adherence of platelets on the tissue. What's interesting about this valve here is the ability of this valve to heat set, meaning that it don't have to have stitches to be able to shape it up. So with 9 stitches on the valve, you can actually have exactly a similar configuration as a sapien valve. This is a balloon expandable valve. You can see the time to manufacture it, the cost, and what's exciting about this is actually they have the ability to go down to a 12 French. Very exciting work. So you can see here, this is a preclinical. And then on a bench testing, you can see that this valve is actually the top one is very comparable to a sapien valve. This is phenomenal. If we can do this, I think that would be great for the field. Lastly, TAVR outcome prediction. So this is again from the same group. So from the top, let's see here. So from the top here, you see that this patient has gotten a core valve, had massive paravalvular leakage. They took the same data and then modeled around this as a tool, and then they have shown that actually with the patient should have gotten Edwards valve rather than actually a core valve. They were able to predict what would be the best valve for this type of anatomy. Below, you can see, again, valve placement. In this particular case, they were able to see what would be the best height for the placement of the sapien valve to prevent any coronary ostium occlusion. In conclusion, know the game and who's the potential acquirer. In aortic stenosis, the TAVR product differentiation is subsiding, so what's next for us? Again, new upcoming technologies may be more robust solutions for AS and AR, so are we going to be looking at new field emerging out of the aortic regurgitation with new valve? So with that, I would like to thank you.